recording. So now we're moving on to the kidneys. I talked about liver, chemistries, and when we get into the kidneys, primarily we're talking about your BUN, which is your blood urea nitrogen, which is a waste product, and then your creatinine. Now, the main test when I'm looking at the kidneys is a BUN. If you guys do what's called a short panel, like a pediatric panel, they'll usually have a BUN. Usually the creatinine is added to like a comprehensive profile. So it's kind of like a backup test to the BUN, but your BUN is your primary kidney test. What we're looking at is it evaluates the kidney's ability to remove nitrogenous waste, blood urea nitrogen. So is the kidney, because think about it, when you pull the blood and you measure BUN, what level of urea nitrogen is in the blood? You know, and I want to say probably your normal, I want to say is like 5 to 25. You know, it could be different with different machines, but about 5 to 25 is what we're looking at. And your urea is what comes from protein metabolism. So, you know, cellular metabolism, protein metabolism in the body is going to, the waste product of that is going to be urea. Now, if we want to, you know, the urea, the liver is going to break down amino acids for your protein metabolism, and then your kidneys are going to eliminate it. You know, so, and I've talked about this in anesthesia. You know, liver usually breaks things down like drugs. They break them apart and render them inactive. And then when they go to the kidney usually excretes inactive metabolites. But remember, when I'm talking about waste products from the body, if it's something broken down in the liver, protein metabolism, the side product of that, or the waste product from that, is the urea. This little box here, 40% of the kidney will not function before we will see an elevation. And I've even sometimes heard 75% of the kidney must be malfunctioning before you'll see an elevated BUN. So, you know, I've talked about blood pressure and how important it is to maintain good blood pressure to maintain kidney perfusion. Because if you have blood flow to the kidney, it oxygenates the cells, you know, the kidney will function, the kidney will make urine, and if the kidney makes urine, you excrete waste. If we lack blood flow to the kidneys, we can impair urine function, we can impair clearance, and potentially reabsorb those waste products in the blood, or potentially damage the kidney. So that's kind of the nuts and bolts of why we're so protective of the kidney. There is a lot of notes under here. If the kidney isn't functioning, not enough urea is removed, the BUN is increased. Now, non-renal causes for BUN elevation. So if you get an elevated BUN in a patient, it doesn't always mean that the kidney is not functioning. So this is what non-renal, then these are reasons. Sometimes it can be that they are, you know, pre-shock dehydration. So dehydration. The other thing is sometimes we have animals that can have a stomach ulcers or stomach upset that can have a little bit of an elevation in BUN. So if we talk about being increased, you know, decreased anorexia, low protein diet. So, you know, finding out what the animal's eating is going to be important. Damage to the renal tubules. So if there's, you know, PCT or DCT damage. Now, what I want you to look at on here, azotemia is the term for an elevated BUN. If it's elevated, we say the patient's azotemic. Now, again, when they talk about pre-renal, renal, post-renal, is the azotemia coming before the kidney, within the kidney, after the kidney? That's all that means. And there's some notes under here. If you do have renal reasons, obviously you can have toxicity to the kidney or ischemia. Now, to review, ischemia is what happens when there's a lack of blood flow to tissue. So if you had a lack of blood flow to the kidney, that's what's called an ischemic injury, meaning for some reason blood flow or that tissue was deprived of oxygen, which will cause damage. And that can cause what's called primary injury to the kidney. Now, post-renal kidneys, if you have an obstruction or some type of a rupture. Now, post-renal, does anybody remember the tubule that leaves the kidney that takes urine to the bladder?
From the kidney to the bladder is ureters.
Ureter. Okay, so say there was an animal that had a stone in the ureter and it caused a blockage. Well, what happens is if that cannot leave the kidney and it can back up, that can cause an elevation, but the problem happened after the kidney, if that makes sense. A ruptured bladder, rupture in the ureter, so there's, so basically there's some reasons that can happen before if it's happening before the kidney, then this shock, dehydration. So if, and again, shock can cause a lack of blood flow because due to low blood pressure, if the animal is severely dehydrated. Now, some non-renal causes, again, protein, fever, steroids, things that we have to look at. Now, the sample, technically serum is your preferred. Sometimes this is done on that heparinized, the green tube, the lithium heparin tube, but the primary sample is going to be serum. The other thing to think about too is that if there is bacteria or it can sit, the bacteria can consume urea, which will falsely lower. So again, common theme is try to get these samples either assessed or refrigerated is going to be your best bet. The other thing I want to mention about BUN, and this is just a little tip, most often we're running it on serum, we're running it on a blood machine, sending it to the lab. We use these sometimes in emergency, they do make a little dipstick called an azo stick, azotemia. And just kind of like when you take urine and put it on a dipstick, you can take a drop of blood and put it on this little azo stick and it'll change color and it can give you an estimation of BUN. So azo sticks, again, your most accurate is going to be do the serum, send it to the lab, but they do make these things called azo sticks and you can get an estimator. If we had to do it very quickly, what if the client didn't have any money? I mean, there's a way to get this value with these things called azo sticks. Now the creatinine, which backs up your BUN, this is really evaluating the glomerular function. So if you remember the glomerulus inside the nephron, which is that filter that initially filters out the urine. So can it filter creatinine from the blood and it gets eliminated through the urine? Okay, so that's where we first kind of talk about. So this is kind of like the first part of the nephron. Remember, blood goes in through the glomerulus, whatever's filtrate or whatever can be pushed out of the blood. And then that makes it into the tubules. And then that will travel through the tubules. And sometimes things get reabsorbed in the tubules, but something like creatinine, once it's filtered out, it should go through the tubules and make it into urine. That's what should happen. This is a byproduct of muscle metabolism. So obviously, think about, we talked about animals like strenuous activity, things that would increase muscle breakdown could affect this result because this is where creatinine, some people call it creatine, it's creatinine, but that's where it comes from. So this tends to be when you do not have functioning glomeruli. And again, a nephron is the primary functional unit of the kidney. And there's, hundreds of thousands of nephrons in a kidney. So do you have enough of those nephrons that contain the glomerulus that are not functioning? And that's the concern. So some concentrations when we can see this, their fluid and hydration levels can always influence these kidney values. So, you evaluate for dehydration, also evaluate for overhydration, but, shock, potentially bladder and urethral obstructions. Anything that obstructs the urethra, the tube leaving the kidney, can cause a backflow. Remember, urine shouldn't go backwards into the kidney, but if it causes a backflow, that's going to affect the filtration, and the kidney can affect these results. It can be done on serum or plasma. Serum is preferred. And hemolysis tends to not affect the results. Anytime a sample is hemolyzed, you guys need to note it in the record or on the lab form, because as the doctor looks at the results, if anything is out of whack, any value, I don't care, they're going to look back and sometimes say, was this a hemolyzed sample? If you guys send it to the lab, a lot of times Antech is going to note. That's one of the first things that's on a chemistry result is the or the quality of the serum. And they might say hemolyzed, icteric, lipemic, because then the doctor can evaluate, is the abnormal result due to drain damage, or is it due to poor serum quality? Now, bilirubinemia, if that is elevated, it can cause an increase here, but you would have to evaluate that with your sample. AJ, come here. AJ. Okay. So any questions about the kidney? A little side note, and it's not in this PowerPoint. Another test that sometimes will back up, if we're really trying to assess kidney function, you can run what's called a phosphorus level. And sometimes that's a more sensitive indicator. We had some renal failure cases, and my doctor would always have me, phosphorus was an extra cartridge. It wasn't part of a chemistry panel, but we had ordered some cartridges because he'd have me take out, sometimes there was one cartridge, he goes, I don't care about this, take out the lipase, I'd rather have a phosphorus. So sometimes I would replace, so phosphorus was another test that can kind of back up, but your primary ones are your BUN and creatinine. Now, when we talk about the pancreas, remember the pancreas has two components, and endocrine, which is within, and then exocrine, which is the, so endocrine pancreas secretes within the bloodstream. The exocrine pancreas is going to secrete into a duct. So your endocrine produces glucagon and insulin. So that's what those two little lines, glucagon and insulin. And your exocrine produces your lipase, amylase, and trypsin. So amylase, lipase, and trypsin. Now, your big thing to understand is that when you're talking about the exocrine function, that is primarily like the digestive component, because the exocrine pancreas secretes the amylase, lipase, the trypsin. Remember, there's a duct that goes to the duodenum, and that's where the exocrine pancreas, and that's for digestion, fats, and carbohydrates because remember, exocrine pancreas needs a duct. So exocrine goes to, and that's your digestive enzymes. Your exocrine function can cause a lot of problems with digestion. But let me talk about the amylase and lipase as our primary pancreas test. So most problems occur in the dog with the exocrine function. So amylase, it breaks down your starch and glycogen. Wow, it's really big under here. So hopefully you're seeing some of this as you're taking notes, but breaks down your starches and glycogen. So, when it's eaten, and we eat a meal and we get the starches, also if glycogen is released. So increased levels can be seen with all of these reasons. So it can be acute, chronic, or obstructive pancreatitis. I will tell you, if we suspect pancreatitis, which can be an awful disease in animals, one of the first values we're going to look at is amylase. We're going to evaluate amylase, and that's going to be really a sensitive indicator of pancreatitis. And dogs will have a much higher level than people, which is interesting, because people can get pancreatitis, they would monitor it in us as well. So, if you went and they talked to you about your amylase, that could definitely be true. Cats, it's not as sensitive as it is in dogs. The sample, you really want to, serum is preferred, or the plasma that comes from the heparin tube. So, but serum is going to, it breaks down starches and glycogen. So I don't know if you can see this on, Rachel, on the bottom of the slide, but it's got some of the answers under here, but glycogen. Which, remember, when your glucose, extra glucose is stored as glycogen. So if glycogen is released, it will be broken down by amylase. The sample, though, that you have to be, it's preferred to be non-lipemic. And the problem is sometimes animals with pancreatitis, or especially if they've had a high-fat meal and it triggered a pancreatitis, a lot of times that will come back lipemic. So it can affect this result. So, that has to be definitely noted if you note lipemia. And hemolysis can falsely elevate. But again, most of the time, guys, pancreatitis, this is going to be elevated. And this is what we're going to look at for that test to confirm. Now, I already told you in the notes here, there can be chronic, acute liver disease, upper GI inflammation, or some type of obstruction. So there's other reasons, but I'm going to tell you the primary thing that we tend to see with that is pancreatitis. But if we suspect pancreatitis, an animal can have one of these other issues. One thing to think about is, and I'm kind of, I tell my friends that have animals, and I belong to a couple of boxer groups on Facebook, and sometimes people talk about giving pork and fat to dogs, and I'm always like, I don't give them any fatty parts. Every once in a while, in a piece, if we have steak for dinner, I'll give the dogs like a little piece of fat off the edge of the steak, but nothing like, here's all the fat, I'm giving it to my dog, because high fat meals, and sometimes if something that's very rich, will get the pancreas flared up. So if I'm talking about acute pancreatitis, usually there's something in the history where the dog was given like a special treat like that, or they got into like fat and oil. There was a pancreatitis case, and animals can die from pancreatitis, but a lady came in, this was several years ago, to my general practice before I was at Purdue, but the dog was so sick. And she's like, well, I just gave it the dripping pan after Thanksgiving. So we were like, you let it eat like the drippings? So like it had bits of skin, but it was like all the fat. I mean, this dog was sick. It was in the hospital for like a week. Because the pancreas is very sensitive, and, trying to reintroduce food, and, so you have to be really cautious with pancreatitis. Now, lipase, obviously, think lipase lipids, breaking down of lipids, which are fats, and it can be more sensitive than amylase, but I will tell you the primary test that we usually look at first is amylase, and then we look at lipase. Yeah, no, I agree with that, Hope. You have to be very careful because, and I never really give my dogs pork. I give them sometimes beef, or they get chicken, but pork can sometimes flare the pancreas. So I don't, if we have ham for Christmas, I don't really give them the ham. No hot dogs, no bacon. This lady on the board, she goes, I think I'm going to give my dog bacon because he's not eating well. And I was just like, oh my God, please, no. All that fat, ugh. Anywho, so it tends to be more sensitive. When we do see an elevated lipase, then, we can see pancreatitis, obviously, is like probably the number one thing. Can be kidney failure, Cushing's, bile tract disease. So you can see there's a variety of things, but it is primarily associated with the pancreas and is typically elevated if they have pancreatitis. So I will tell you there's a note here that it is produced in the pancreas and the stomach, but usually when we're measuring it, the bulk of what we're going to see is coming from the pancreas. So normally we're not, even though there's a note about it being produced in the stomach, we primarily going to look. Now your serum, which should be non-lipemic and non-hemolyzed, because that will affect the results. You can, again, heparinize plasma. So hopefully you're seeing that we can use these tests or these samples interchangeably. Okay, and now glucose, it's a primary thing to look at. But, you know, when an animal eats, they digest the carbs. That's where we primarily get glucose, is from a meal. And when an animal eats, they're going to access some glucose. What is left over, I kind of have talked about this in anatomy, like you put the leftovers in the fridge. If there is leftover glucose, it can be stored as glycogen. So, you know, if it's stored, it's not, you know, glucose anymore. So the body can access, you know, primarily from a meal or stored glycogen. And this is a source of energy. Now, to access glucose, they need a hormone to take glucose from the blood and put it into the cells and access that for energy. And that is going to be insulin. So insulin is the primary hormone, and it is produced by the beta cells in the endocrine pancreas. So insulin comes from the endocrine pancreas. And insulin, when it's released, it's stimulated by, you know, they eat a meal. When they, excuse me, the release is stimulated by glucose and amino acids. So when they start to eat and they realize there's glucose, there's stimulus, insulin is released. Insulin is going to move that glucose in, and then when glucose levels drop, there's no longer a stimulus for insulin. So if you remember, hormones are responding to, like, they monitor these levels, and there's always a stimulus to release a hormone and always a stimulus to stop releasing a hormone. Yes, Lauren, and you know what? I think she got that analogy also from Sipes. So the analogy is, you know, like if you are sitting at your table waiting for your food, you are the cell, and then the kitchen makes your food. But I can't go, you know, normal people don't go in the kitchen and get their food. A waiter brings it to your table. So when the food is ready, like an animal eating a meal, an insulin, or like the waiter, brings me my food and I can access it. So if you can see what happens when an animal does not produce insulin, like in diabetes, they eat a meal, they have glucose, but the problem is the insulin isn't there to move it into the cells. And that's why we tend to see hyperglycemia, because the glucose is in the blood, not in the cells, because it's lack, and that's why we give insulin, is to, you know, for some reason there's damage, and it's not allowing insulin to be released and move the glucose where it needs to go. So now decreases when blood glucose levels, you know, drop. So when glucose levels come back to normal, there's no stimulus anymore for that insulin. So right here, it decreases when glucose is uptaken, or it's metabolized by the liver, moved into other tissues. Now, if you guys remember, there's two sides to glucose levels. So when it's high, insulin's released and brings it down. But what happens when there's low glucose levels, when there's not enough glucose? Then we have to deal with glucagon. Now, growth hormone, catecholamines, but primarily glucagon is going to be released, and that's going to cause glycogen to be released and turned into glucose where they can access. Okay, so you got two sides to it, because the pancreas is producing, if I go back, the exocrine pancreas or the endocrine pancreas produces the glucagon and insulin. Insulin lowers blood glucose, glucagon raises blood glucose. So if an animal's not eating, that stored glucose, that was the leftovers, can be accessed. And glucagon is what accesses that, and then it will it'll mobilize glucose in the blood, elevate it when needed. Now, when we look about glucose levels that you're measuring, we're going to have hyperglycemia, which is elevated, hypoglycemia, which is low. So reasons for hyperglycemia typically is diabetes mellitus, is, when the animal's diabetic, they will usually present with hyperglycemia. But the other thing is stress can cause hyperglycemia. A lot of times, cat blood samples, you'll see like a slight elevation in glucose, and people like, oh, this animal's hyperglycemic, but the cat was fighting us trying to draw the blood, or it came in stressed from the car ride, and then it was stressed in the back. So sometimes, the doctor might say, hey, let's have them come back in a week and let's redraw that and recheck it. Because if we think there was stress involved, it could just be as simple as there was stress. And it's called, stress hyperglycemia. Can also be seen in Cushing's. So that has to be looked at. Now, hypoglycemia, when we don't have enough, then we tend to have animals, they're, malabsorption, which means, maybe they're eating, but they're not absorbing from their diet. So there's a lack of absorption there. Liver disease can cause that. But the other thing is this note here, prolonged contact with the serum and the cells. If you guys leave out a tube, like you draw it in the morning, you go into surgery, you go to class, and that evening you're like, oh, I got to run my chem panel. And that tube's been sitting there. Remember, the cells in the clot can consume the glucose from the serum, and that can cause a hypoglycemia. So, and also think of like little guys. Little guys can get hypoglycemic, if you've got these pediatric patients or they haven't eaten, my friend had a Yorkie poo, tiny, tiny puppy. And I was like, you got to keep some Caro syrup around the house, because your dog goes a day or two with not eating or a day or two of vomiting, glucose levels can drop pretty quickly. Now, most animals will need to be fasted to get a true glucose level, so generally this is best from a fasted sample. It does say 16 to 24 hours. Normally we say 12 hours for like normal blood work. And, this is always doctor dependent. I always say, ask my doctor, say, what do you want me to tell the client? But and make sure they can't get, but when you centrifuge it, the big thing is you want to remove the cells immediately. So, and like I said, to be safe, you can use the serum separator. If you don't have a serum separator and you spin it, you definitely need to suck off that serum and put it in like a clear tube and keep that separate so that you can send it to the lab. Now, it says to not fast ruminants. If you remember, so their main source of glucose is neogenesis from fatty acids, absorbed from the rumen. So, and again, in cattle, even if they were to not eat, that rumen is holding food contents from, a day or two, maybe 3 days, and that is going to affect the results. So actually, let me just stop here before I get into the electrolytes. Yeah, let me pick up with electrolytes tomorrow.